Hello, my name is Brenda Mars. I'm a family nurse practitioner student, and I'm here to take care of you. Can you, before I begin, can you state your full name and date of birth?
Felipe Ramirez, 1 May 1989.
Okay. Do you know why you're in here?
Getting a physical exam.
Okay. So I'm going to begin a musculoskeletal exam, and before I begin, do I have permission from you to record so that
Yes.
my professor can view this content?
Yes.
All right, so I'm going to begin the musculoskeletal exam by assessing the hands, and I'm going to start assessing the fingers. I'm looking at the hands, any discoloration, any redness, any joint dislocation, symmetry, and I'm going to be looking at both hands, and I'm looking for atrophy as well, any joint deformities, any swelling or redness that I see. Once I'm done inspecting the hands, I'm going to start assessing range of motion. So Mr. Ramirez, can I have you, no, leave your hands up. Can I have you make a fist for me? And as I'm assessing for range of motion, I'm assessing to make sure that it's symmetrical and the patient is free from pain. Let me know if you have any pain during any of these ranges of motion. I'm assessing for tenderness and then any limitations to the range of motion or any spasms that I may notice. Now you can extend your hands, and now we're going to flex the fingers, and then we're going to extend the fingers. I'm assessing the rhythm of movement. Now that I'm done assessing the range of motion, I'm going to palpate. I'm going to start by palpating the metacarpal phalangeal. And as I'm palpating, I'm feeling for any tenderness that he may feel. I'm looking at his face to see also if he has any pain, feeling for nodules, any heat that I might feel. So I'm going to the metacarpal phalangeal, and then I'm going to go to the proximal interphalangeals and the distal interphalangeals. And I'm just going to assess each one. And I'm assessing for any swelling fluid that I might notice. And I'm going through each finger. And I'm going to do it on both sides. And I'm going to feel. Going to the metacarpal phalangeals, the proximal interphalangeals, and the distal interphalangeals. Working my way down. That's palpation. Now that I'm done assessing the hand, I'm going to go to the wrist. I'm looking at the wrist for any deformities, any swelling that I can see, any nodules, any atrophy, any redness, rashes, or skin discoloration. I'm going to assess on both. I'm going to be looking at both. So if they have a watch on, you could just move it and then you can assess. They should be, I like to assess symmetry for both sides and just to make sure they're symmetrical. I don't see any bulging, they're symmetrical, and no signs of discoloration, redness, or swelling, or joint dislocation. Now that I'm done assessing, I'm going to assess the range of motion. So I'm going to have, Mr. Ramirez, I'm going to have you flex, and I'm going to have you extend the hands. And during range of motion, I'm assessing again if the patient is in any pain, any tenderness. I'm going to have him also tell me throughout all range of motion. And I'm assessing for any limitations in the hands or any spasms. So now flex again. Now we're going to do radial deviation. So you're going to go in, and then we're going to do ulnar deviation. Good. Now that we assess the range of motion with the wrist, I'm going to start by palpating the wrist. I'm going to palpate the radial and ulnar bones. And I'm also going to palpate the metacarpal. And I'm feeling again, as I'm palpating, I'm feeling for any heat, tenderness that he might feel, any swelling, and I'm feeling the whole hands. And I like to compare one hand to another. I don't see any, I don't feel any nodules. I don't feel any edema. Now I'm going to assess the other hand. Again, you're going to assess the ulnar and the radial and the metacarpal area. And assess if he has any pain. Any pain, Mr. Ramirez?
No.
Okay. Now that we did that, I'm going to do a special test. This is called the Tunnel's sign. This assesses for the median nerve for any pain. So what I'm going to have him do is I'm going to have him hyperextend, yep, the hands, and I'm going to start with one side and then I'll do the other. So what I'm going to do is with the middle finger, I'm going to percuss all the way up. If he feels any pain or paresthesia, it would be a positive Tunnel sign. So I'm going to go up. Do you feel any pain or paresthesia? And if you were to feel pain in the thumb, the index finger, the middle finger, or the lateral ring finger, it would be a positive Tunnel sign. And I'm going to assess the other side. And this would mean carpal tunnel syndrome. So I'm going to start. And you're going all the way down to that median nerve, all the way to the elbow. Did you feel any numbness or pain? Any paresthesia? So that was the Tunnel sign. Now we're going to do another sign for carpal tunnel syndrome. This is called the balance test. So, and he's going to do this for 60 seconds. And in those 60 seconds, if he feels any pain or paresthesia on that side, it would be a positive balance test. And again, in that median nerve, the thumb, index finger, middle finger, and the lateral ring finger. All right, and it could be like 45 to 60 seconds. Did you feel any pain?
No.
Okay. So that's the wrist assessment. Now we're going to go down to the elbow. And again, I'm going to assess. I'm just looking to see if there's any bulging. I'm assessing for any swelling. Can you turn around, Mr. Ramirez? Any swelling that I might notice on the elbows. And I like to compare both. I like to look at the symmetry. I'm looking just to see if there's any nodules, any edema, any redness, or if I see fluid sticking out from there. And that's what I'm looking for on inspection. Now I'm going to assess the range of motion. So I'm going to have Mr. Ramirez. I'm going to have you flex. So you're going to flex. So I'm going to have him flex, and then I'm going to have him extend. So you're going to flex and extend. Yeah. So flex and extend. And I'm assessing through the range of motion to see if there's any limitations, any pain while he's having that. Do you have any pain, Mr. Ramirez?
Okay.
And I'm assessing also for symmetry. Are those rhythmic movements without any limitations or spasms? And that's the range of motion of the elbow. Now we're going to do pronation. So you're going to place your arms down, and then supination. Got it. And again, pronation and supination. And I'm assessing to see also if he has any deviation limitations. And that's going to be throughout the range of motion. Good. That's the range of motion of the elbow. Now I'm going to begin palpating. So I'm going to palpate that olecranon process, which is the bony part of the elbow. And I'm just going to feel to see if there's any nodules, tenderness. You feel any pain?
No.
Any signs of fluid that I might feel, or misalignment that I might feel. So that's the olecranon process, and then the lateral epicondyles. So I'm also going to feel to see if he has any pain, tenderness, no heat, no warmth. And I'm also going to feel now the other side, going to the olecranon process and the epicondyle spaces. Now that I'm done palpating, that's the wrist, that's the elbow assessment, and now I'm going to assess the shoulders. And I'm going to assess the shoulders anteriorly to assess for any symmetry, any redness, any bulging, maybe one side's bulging more than the other. It looks symmetrical, but you also want to look at the back. So I'm looking anteriorly and posteriorly on the shoulders. Any symmetry, redness, swelling, um, and edema, atrophy maybe on one side. So now that I assessed, what I'm going to do is I'm going to assess full range of motion, and I'm going to have your forward face. So the full range of motion, so we're going to do frontal flexion, so you're going to bring your arm front. And again, during the range of motion, I'm assessing for any, I'm looking for the rhythmic movement and any limitations, spasms that he might have, or you can bring your arm back down, or pain that he might have, tenderness. So we're going to do it on the other side as well. Good. Bring it down. And then can we do both together? Good. Now we're going to do a hyperextension, going back. And I'm assessing, same again, range of motion, bring it forward. Good. Now I'm going to assess that scapular motion. The scapular motion should be a rhythmic movement sideways, like that, and going all the way up. Good. And it should be symmetrical. One arm should not drop. It should be a symmetrical, rhythmic movement, free from limitations. That's the scapular motion. Now we're going to abduct, so you're going to place your arms out. And now you're going to add your arm. You're going to bring one arm in towards your body. Yep, like that. Bring it in. Yep. Yep. And that's adduction and abduction. You can bring it down. Now do the other one. Adduction, abduction. And then we're going to do external rotation and internal rotation. So you're going to bring your arms behind your head, and you're going to bring your arms behind your back. And I'm assessing for symmetry and full range of motion, free from any limitations. And that is the range of motion of the shoulder. And now I'm gonna palpate, and I'm palpating to see if there's any swelling that I might feel, like warmth. I'm feeling if he has any pain or tenderness or fluid that I might feel. So I'm gonna locate the clavicle. And then I'm gonna move in laterally to feel that acromioclavicular joint, which joins the clavicle and the scapula together. If you're not sure, you can go behind in the scapula and work your way in. So you're gonna, I'm gonna feel the acromioclavicular joint, and I'm feeling again any tenderness, any pain, any swelling or fluid that I might feel. And now I'm going to go down to the coracoid process. Coracoid process is a bone from the scapula that's sticking out anteriorly. And if you're not sure if you're actually feeling the bone, you can have your patient bring his scapula kind of forward, and it'll kind of move the arm forward, and then it'll stick out. You'll feel that bone, bring it back, and then you shouldn't feel it anymore. So and I'm gonna do this side first, and then I'm gonna do the other side, because you want to assess both sides. So acromioclavicular joint, go down to the coracoid process, and then I'm gonna go down laterally to the lesser and greater tubercle of the humerus. And you can assess this better by having the patient move your arm front and back. Do you feel any tenderness? And you could try and see for any fluid. Okay, bring your front forward. Now you're gonna feel that bicep groove, and I'm feeling again. I said during palpation, I'm feeling for any pain, tenderness, or fluid. You feel any pain? All right, bring your arm forward and back, and you're just feeling that bicep groove. Once I'm done from the bicep groove, I'm gonna go towards the, I'm gonna feel that deltoid, subdeltoid, bursa. I'm gonna look and feel for that subdeltoid bursa. And that's between the deltoid and the capsule. And Mr. Ramirez, can you bring your arm forward and back? Good. Any pain?
No
Okay.
pain.
Now we're going to go back to the other side. I'm locating clavicle, going down to the acromioclavicular joint, AC joint, and I'm palpating again for any tenderness, pain, or fluid. Go down to the, and you didn't feel any pain?
No pain.
Coracoid process, bring your arm forward, bring your back, good. The lesser and greater, the lesser and greater, lesser and, I just said the name, tubercle of, lesser and greater tubercle of the humerus. Move your arm forward, move your arm back. Now we're going to go to the subdeltoid bursa. I'm going to locate right here. Bring your arm forward and bring your arm back. And that's palpation. Now, now that I'm done palpating, I'm going to do a special test to assess for any shoulder injury. So this is called the Hawkins test. It assesses for the supraspinatal tendonitis. It assesses for supraspinatal tendonitis. So what I'm going to do is if the patient has any pain, he would have a face, and that would be a positive Hawkins test. He would be in pain, and I'm going to try and rotate. So you're going to bring it in and rotate back and assess to see if he has any pain.
Okay.
Okay. Push back. Any pain?
No pain.
Okay. And that's any shoulder misalignment. That's the supraspinatus tendonitis. That's assessing for. And next, after we're done with shoulders, I'm going to start assessing the head and the neck. So with the head, I'm going to inspect. I'm inspecting for any deviation, deformities, any lacerations or side drooping that I might see. And it's symmetrical. After I'm done inspecting, and I'm inspecting from both sides, anteriorly and posteriorly. Once I'm done inspecting, what I'm going to have him do, now I'm going to assess for flexion of the neck. So Mr. Ramirez, flex your neck and extend your neck. So look up at the ceiling. Now you can bring your neck back, and we're going to touch your ear to your shoulder. So you're going to go, and that's the lateral neck motion. Good. Now we're going to rotate his neck. So you're going to touch your chin to your shoulder. And again, during range of motion, I'm assessing for limitations, any pain, tenderness that he might have, or any spasms that he might have. Now that we're done doing neck range of motion, I'm going to assess the mouth. So I'm going to assess the widening, opening of the mouth, and he should be able to open his mouth wide enough with three vertical fingers. So start off by opening and closing the mouth. Okay. Now, can you just place 3 fingers in front of your mouth? Okay, good. And now I'm going to have you assess, and he's going to go move his mouth laterally, so kind of, yep, just like that. And then now I'm going to assess the TMJ joint. I'm going to place my 2 fingers right in front of the tragus, and I'm going to have him open and close his mouth, and tell me if you have any tenderness or pain.
Okay.
And that's assessing the temporomandibular joint. Now that we're palpating, I'm going to locate the the sternoclavicular joint, and every time I'm palpating, I'm feeling for any warmth, edema, tenderness that he might have, or if I notice fluid or any nodules at that area. So from here, any tenderness?
No.
Now I'm going to go to the back. And I'm going to be assessing the cervical spine, and I'm going to feel from C1 all the way down to C7, and I'm just palpating to see if there's any vertebrae, any vertebrae slip off. So if one of the vertebrae is slipping off more forwardly, and I'm just feeling. So we're gonna go here and work all the way down. Okay, and now I'm gonna assess the post-cervical muscle, the paracervical muscle, and I'm gonna also assess the trapezius muscle. And you can move the scapula out the way so you can feel. Mr. Ramirez, tell me if you have any pain on palpation.
Okay.
Good. And now I'm going to assess the major and minor rhomboids, which are the minor are right at the C7, and the major are from T1 to T4. And I'm just assessing for any pain that you might have.
No pain.
No pain. All right. So that's the cervical. Now that we're already in the back, he didn't have any pain. I did palpation. Now I'm going to do a special test, the Sperling test. This, you can actually turn around so that they could actually see. The Sperling test would be, it's assessing for any cervical herniation that the patient might have. And what I'm going to do is I'm going to have him externally rotate his head. You're going to rotate your head, and if the pain was on this side, I'm going to apply pressure. And once I apply pressure, if he feels pain, so you're going to kind of bring your head kind of down, yep, just like that. If I apply pressure on this side, he might have pain or paresthesia radiating down this arm, and that would be a positive Sperling test. So I'm going to push down. Any pain?
No pain.
Okay. Now we're going to go this way. Any pain?
No pain.
Okay. And that's a negative Sperling test, but if there were pain, that would be a positive Sperling test. Now we're done with the cervical. We're going to assess the spine. So the spine, I like to look posteriorly and laterally. I like to start off by just inspecting. I'm looking for the shoulder looks symmetrical, the iliac crest looks symmetrical, and then the bottom of the buttocks, the skin folds would be symmetrical as well, to let me know if for symmetry. I'm also looking for lateral. So you should notice that concavity, convexity, and convexity of the spine. From the cervical, thoracic, lumbar, and sacral area. It shouldn't be pertinent, and you shouldn't really, it shouldn't be noticeable, because then that would be a sign for lordosis in the lumbar or cervical area, or kyphosis in the thoracic area. So concavity would be from the cervical and lumbar, and the thoracic should be concave, as well as the sacral area. That's my assessment. Now I'm going to have Mr. Ramirez, I'm going to be inspecting, as well as he is assessing range of motion. He's going to forward flex, so you're going to go slowly, and I'm assessing his shoulders if they're going symmetrically. And he's going to go slowly to touch his toes, and I'm assessing for that range of motion if he's able to do it, if the shoulders are going down symmetrical. And also, if he had scoliosis, you want to assess that vertebrae, that it's nice and smooth. It's going up and all the way down. It's not zigzagging or making an S. like in scoliosis. I'm also making sure that he can at least go down 90 degrees, and he should have that C curvature, smooth curvature, when he flexes down. So that's spinal flexion should be at least 90 degrees. Mr. Ramirez, you can go back up. And that's when you're assessing. Also, when he was bent over, when he's bent over, you want to assess the hips if they're also symmetrical. So okay, and again, you just bend over, and I'm assessing the hips if they're symmetrical. You can go back up. Now I'm gonna assess for extension. So he should be able to go at least 30 degrees. Yep, that's extension. And now we're gonna assess the range of motion. Again, during range of motion, I'm always assessing for symmetry, rhythmic movement. If he has any limitations, any pain, let me know if you have any pain or tenderness while you're moving, or spasms that I might notice. So now he did extension. We're gonna do a lateral movement of the spine. Good. And that should be at least 35 degrees. Okay, you're gonna do this on both sides, lateral movement. And then we're gonna do rotation of the spine. You're gonna rotate this way, and that should be at least 30 degrees. And I'm assessing to make sure there's rhythmic movement. Good. So that's the range of motion of the spine. Now I'm gonna palpate, and I'm just gonna feel that spinous process and the intervertebral spaces. And I like to do it with 3 fingers, and I like to work my way down to see if there's any slip off of the vertebrae. Also, let me know if you have any pain. And I'm also feeling if there's any swelling, and you're gonna go all the way down. Any pain?
No pain.
And there was no vertebrae slip off. Now I'm gonna also percuss with the ulnar side of my fist, and I'm gonna percuss. If he feels any pain, he will. I would want him to let me know. So I'm looking for pain. Any pain, Mr. Ramirez?
No pain.
Any pain?
No pain.
Okay, that's the spinal assessment. Now we're going to start off with the hip. With the hip, I like to lay the patient down. So, Mr. Ramirez, I'm going to have you lay down. And in the hips, you want to assess, you want to be inspecting. You're looking at, you're going to look at symmetry, if there's any dislocation that you notice, any joint deformities. You want to look at those hips, if there's any redness, swelling, or nodules. And that's what I'm looking at with the hips. Once you're done, and you're going to look anteriorly and posteriorly. I'm going to look posteriorly once he turns around, because I'm going to have him extend his foot. But anteriorly, so once I'm done assessing, I'm going to start range of motion. And the range of motion I'm going to do, is going to be active and passive movement. So I'm going to do it first, passive movement, and he's going to do it after I show him. So I'm going to start with flexion of the foot. So I'm going to flex the foot, and it should be able to move 90 degrees. And as I'm assessing range of motion, I'm making sure that he's not in any pain. Let me know if you have any tenderness. I'm looking to see if I hear any cracking, any signs of pain that he might have, or cracking, or hip dislocation that I might cause. And the hips should be able to go back in place the way it was. So that was flexion on one leg. So now I'm going to passively flex the other leg, at least 90 degrees. Good. Any pain?
No pain.
Okay. And no limitations or spasms. Now that we're done with flexion, I'm gonna have you do actively movement. Okay, good. Okay. That's flexion of the hip. I'm gonna have you turn around, Mr. Ramirez, and I'm gonna assess extension of the hip. And he's gonna bring his foot back. That should be at least 10 to 20 degrees. Okay, and that's active movement, so that's fine, you can do it, and then I'm gonna help you. So I'm gonna because I'm feeling for any crepitus as well. I like to feel to see how that joint moves. Um, if I feel any crepitus or cracking as I'm feeling, or I can also hear. And I'm also going to inspect the hips posteriorly for any nodules um, or hip dislocation. And now that we're done with that, you're going to turn back around and I'm going to assess for internal rotation, external rotation. So I'm gonna passively move him, place the foot 45 degrees. I'm gonna internally rotate and externally rotate and bring the foot right back to its original place. And I'm gonna do the same thing. Internally rotate and externally rotate. Bring the foot to the same place. And now that was passive movement. Now he's gonna do it. Mr. Ramirez, can you do it, please? Good. There's no signs of limitations. I don't hear any crackings, and he's able to bring his hips back into place. He looks comfortable. Once I'm done doing that, I'm going to that's flexion, and now we're gonna abduct and adduct. So we're gonna move away from the body. So I'm gonna help him out. We're gonna move away passively. And then we're going to bring his foot inward. Good. Now he's going to do the same on the other side and bring it across the other foot. That should be at least 30 degrees and abduction should be at least 60 degrees. And free from limitations. Now I'm going to palpate the hip and I'm going to locate specific areas. I'm going to palpate the anterior superior iliac spine. And as I'm palpating, I'm feeling for any pain that I might cause him, any tenderness that he states, any warmth, edema, nodules that I might feel, or dislocation. And I'm gonna feel, I like to assess one and then compare it to the other one. All right, good. And now I'm gonna assess for the greater trochanter, which is lateral. Any pain?
No pain.
Okay. I'm actually going to have you turn around again, I'm sorry, and I'm going to feel, because I thought with the couch is not really that easy, and I'm going to assess the posterior superior iliac spine. Any pain?
No pain.
Okay. And now I'm going to assess the sacral, which is like right next to the dimple, sacroiliac joint. Any pain?
No pain.
Okay, now that I'm done palpating, I'm going to do a special test for the hips. So, Mr. Ramirez, sorry, can you turn back around? So this is called the Thomas test. This is going to assess for any for the flexion of contraction, hip flexion contraction. So I'm gonna move his foot inward. And the other foot should stay flat. And I'm gonna also place my hand on the bottom of the lumbar spine because it should be flat. If he were to try and compensate with the other leg, or with his lumbar curvature, creating that the concavity, it would give me a sign of positive Thomas test. Thomas test. You're going to go, so you're going to bring in with both your hands, you're going to push in. Good. All right, and then the hip should be able to go back in place. Now we're going to go in, bring, and I'm feeling at the bottom of the lumbar area, and I'm assessing this leg as well. Okay? He continues to have that lumbar flat, and he's not using extra, like his foot bending or the curvature of the lumbar to help. He's able to freely move that hip and put it back in place. The next one is going to be the Patrick test, and this is assessing for hip or the sacroiliac joint disease. So what I'm going to do is I'm going to have him place his foot right on top of his femur, and I'm going to push down. And if it causes any pain or paresthesia, and especially at that hip area, it would be a positive Patrick's test. Do you feel any pain?
No pain.
Okay. Now we're going to do the other side. Any pain?
No pain.
Okay. That's the Patrick's test. Now that we're done assessing the hip, we're going to start assessing the knee, the kneecap. And again, I'm going to inspect. The whole time I'm inspecting, I'm looking for any deformities, any malformation. I'm inspecting one from the other side, and I'm looking at both. Any nodules that I may see, any redness, joint deformities, or dislocation. Once I'm done inspecting, I'm going to assess the range of motion. With range of motion, I'm going to have you sit, and I'm going to have him extend. Okay, extend. And then can you stand up and then flex your leg? It should be at least 120 degrees. Okay, and now you can sit back down. I'm going to assess the patella, and it should be free of movement. It should be able to be movable. I shouldn't feel any swelling, warmth, or fluid that I might feel. And then I'm going to feel also the suprapatellar pouch, and I'm feeling, do you feel any pain, tenderness?
No.
I don't feel any fluid as well. Do you feel lateral? And I'm going to feel on both sides, the patella, suprapatellar pouch, and I'm feeling no pain, no nodules noted, warmth. And now I'm going to assess also the popliteal, the popliteal fossa, which is right behind, and that's where you feel sometimes for a Baker's cyst. A Baker's cyst would just be like a little bulging in the back. And I don't feel any pain, tenderness. I don't feel any nodules. And I'm assessing both sides. No?
No.
Okay. So that's palpation, and I'm going to do some special tests on Mr. Ramirez on the kneecap. So I'm going to have you lay back down. Oh, and also when I'm inspecting, I'm trying to assess if there's any vagus or varus dislocation. So any valgus, I remember by gum. So the two knees are bringing inward, and then valgus would be outward. And I don't see any deformities. And that's what I'm going to do with the special test. It's called the valgus test. So the valgus test, I'm going to try and see the kneecap. I'm going to try and bring it in. So I'm going to grab tibia. I'm going to bring it in, and I'm going to try and push the lower part of the foot out and the kneecap in. If he has any pain, that would be a positive valgus test. A varus test would be now I switch my hands and I bring it out and the bottom of the foot in, and that's the valgus test. And that would be positive. And I'm going to assess both sides. Let me know if you feel any pain.
No. No pain.
Okay?
No pain.
Okay. Next, now that I did the valgus and the varus, I'm going to assess. I'm going to do the Lockman test, which I'm going to bend, and I'm going to hold the. This is assessing for ACL. And I'm going to assess for the ACL or PCL tear, which is the. So I'm going to assess for ACL or PCL tear, and this is the Lockman test. I'm going to sustain the femur, and then I'm going to bring the tibia up kind of bring it up and back, up and back. And that's assessing the flexity of the ACL joint, the ACL and the PCL. If I notice it's smooth and has no stop to it, which it should, it should have a stop to it. If it doesn't have a stop to it, it'd be a positive Lockman test. And you're gonna assess on both sides, and that would initiate a ACL or PCL tear. Okay, so I'm gonna bring it in, and I'm gonna bring it out. So I'm gonna hold it, push out, push in, and it stops. It shouldn't let me keep pulling on that flexity. Another test is that was the Lockman test. The next one is going to be, I'm going to do the McMurray's test, or the drawer test. I'll do the drawer test. I'm going to sit, so you can sit on the patient, hold pressure, and it's like a drawer. You're opening and closing it. So that's another test for ACL or PCL tear. You're going to push towards you and push in towards the patient. And you're assessing that laxity of the ACL or PCL. It should not be smooth, and it should not be have no stop to it. Like you can just keep pulling. There should be a stop, and that's exactly what I feel. But if they had an ACL or PCL tear, that's what it would mean. Any pain?
No pain.
Okay. So I would do the same thing on the other side. Sorry. And drawer, anterior, posterior. Okay.
No pain.
That's the drawer test. The next one I'm gonna do is the McMurray's test. And that one I'm just gonna basically, I grab the tibia and the femur, and I'm gonna bend it, and as I'm internally rotating that tibia, and I'm gonna try and extend it. If he has pain, that'd be considered a positive McMurray's test. And I'm gonna internally rotate and extend, internally rotate and extend. And those are the tests for the kneecap. Those are the special tests. Now that I'm done with the kneecap, we're gonna go down to the ankle. So now, Mr. Ramirez, you can have a sit, okay? So I'm assessing that ankle. So in the ankle, I'm assessing just for any swelling, deformity. Oh, and the kneecap. I already palpated. Okay, I already did the special test. Now I'm gonna do the ankle, and I'm assessing for any redness, swelling, any signs of deformities, any nodules that I feel on the other side, redness, and I'm gonna look at both. And I'm inspecting. Once I'm done inspecting, what I'm gonna do is I'm gonna assess the range of motion. So what I'm gonna have Mr. Ramirez do is I'm gonna have him plantar flex, push your foot down, and and dorsiflex. And again, during the range of motion, I'm assessing for any limitations, any pain that he might have, tenderness. Okay. And then I'm gonna have him do a full range of motion. Good. On the other side. Good. Now I'm gonna, now that I assess full range of motion, I'm gonna palpate, and I'm gonna feel that Achilles tendon. And I'm palpating to see if he has any pain, nodules, edema. And I'm gonna assess on both feet. Any pain?
No pain.
Once I'm done palpating, now I'm going to I'm going to assess the feet. Um, I'm gonna have him curl your toes and extend the toes. And as he's doing that, I like to inspect the feet. I'm looking for if he has any calluses, any corn on the feet. The bottom, I'm assessing for any, to see if he's flat foot, any lesions that I might notice, discoloration, redness, or if he could possibly have something stuck on his foot and he didn't notice. So I'm assessing everything about the foot on the bottom. Good. Once I'm done inspecting, we can do the range of motion. So you could flex your toes, extend your toes, flex your toes. And now we're gonna do inversion and exversion. In, yep, that's in, and that's X. In, X version. Okay, that's the foot. Now I'm going to start palpating. I'm gonna palpate the metatarsal area. And then I'm going to assess the interdigital, I'm going to assess for the neuroma. Usually it's in the third or fourth, uh, uh, it's between the third and the fourth most common phalangeal. It's more common in women than in men, and they say it's because of the tight foot shoes that they wear, so it's recommended to wear comfortable shoes, a little bit more spaced out. And I'm just gonna feel, I'm palpating especially down those nerves. And do you have any pain?
No pain.
No pain. And I'm assessing to see if he has any pain in that. If he were to have pain in this area, it would be a positive Morton neuroma. It would be positive for Morton neuroma, which would be right here. I'm also going to start palpating. I'm going to palpate the proximal interphalangeal and the distal interphalangeal, as well as the metatarsal. I already palpated, but I'm going to palpate throughout. And I'm palpating to see if I feel any warmth, redness, warmth, inflammation, nodules, pain that he might have on each toe. And I'm going to go on both sides. And that about concludes our musculoskeletal assessment.